welcome to NOAHE Round 7, Session 7. I'm Negor Razavilar, a health economist and data analyst at the Institute of Health Economics and the NOAHE manager, and I will be facilitating today's session. Please join me in welcoming our presenters, Dr. Beall and Jane Fletcher. Dr. Beall is a population health researcher who works largely with medicine patent, regulatory, and utilization data to investigate the long-term impacts of national and international policy decisions that aim to balance incentives between equitable drug innovation and equitable drug access. He is an assistant professor in healthcare policy in the Department of Community Health Sciences within the Cummings School of Medicine and at the O'Brien Institute for Public Health at the University of Calgary. He also serves as affiliated faculty for the program on regulation, therapeutics, and the law, known as Portal, based within the Division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital and Harvard Medical School. Jane Fletcher is a PhD student at the University of Calgary in the Department of Community Health Sciences, focusing on health services research. And she was also the 2023-2024 NOAHE Fellow. Her research is centered around medication access for people facing financial and other barriers, as well as determining other factors around medication non-adherence. Today's topic is public prescription drug plans across provinces and territories, a national environmental scan and public policy analysis in Alberta. Our presenters conducted an environmental scan to gather details on existing public medication coverage plans across Canadian provinces and territories, followed by a public policy analysis. The results of this policy analysis are expected to inform provincial decision makers and public insurance providers of potential options to improve drug coverage for working age Albertans who currently have inadequate coverage. Before we begin, I'll go over some event housekeeping. Participants will be muted throughout the webinar. To submit any questions during the webinar, please use the Q&A function. Just a friendly reminder that the Q&A function is different from the chat function. The Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. Thank you again for joining us. I will now hand over to our presenters.
Great. Okay, so I'm just gonna jump right into it. So we were looking at the study, so we're kind of looking at medication adherence and how different policies can actually affect medication adherence in people. I think I skipped, there we go. Sorry, I'll just start off with some background about some previous studies examining how medication coverage can influence adherence and outcomes. Medication adherence can be kind of less than ideal for a number of reasons. And a major reason is when people experiencing financial barriers to obtaining their prescribed medications have difficulty affording and obtaining those medications. So just a couple previous studies that have looked at this. A study coming out of BC in 2007 compared adherence while the drug plans were changing from full coverage to co-pays, which is a fixed dollar amount paid per prescription, to co-insurance, which is a percentage-based amount paid per prescription, and showed that the introduction of cost sharing did actually have a negative effect on adherence. And then a 2009 study from Zhang looked at how enrolling in Medicare Part D, which is a program extending coverage in the States for Medicare beneficiaries using cost sharing, people who had coverage through the Medicare Part D plans actually showed increased use in indicated medications. And then a 2014 study in Quebec looked at characteristics that might actually be associated with non-adherence, finding that it was associated with younger age, more expensive drugs, lack of coverage for lower income people especially, and use of cardiovascular drugs as well. Sorry, my slide's done. There we go. And then two other recent studies that actually suggested further research was needed were MI-Free in the US and then Clean Meds in Ontario, both relatively recent studies. So MI-Free looked at the impact of covering essential medications post-MI, and then Clean Meds looked at covering essential medications for people who reported kind of suboptimal coverage due to cost or financial barriers. Both studies showed that there was improved adherence for the interventions, about 4 to 6% for MI-Free and then 11% for Clean Meds. And while MI-Free didn't show any improvements for the primary outcome of their first major vascular event or revascularization, The intervention did reduce the total rate of major vascular events, and then a secondary measure of improved blood pressure was also seen in clean meds. And then both studies actually did show lower healthcare costs for people receiving that additional covered intervention. So kind of with these studies in mind, the ACCESS trial was designed after looking at those evidence from the previous investigations, and then also a survey that actually indicated that 1 in 5 Western Canadians with chronic diseases actually had difficulties affording their medications for their chronic diseases. We also found that people with chronic diseases who experience those financial barriers had significantly worse outcomes than those without those barriers. We end up enrolling around 4,700 Albertans age 65 plus, so seniors, and who had household incomes lower than $50,000 a year, and also had chronic disease that made them eligible for the study. And then half were randomly selected to have their co-pays for their chronic disease medications reduced from 30% under that current Alberta Seniors Blue Cross program to 0%. So they had fully covered medications for their chronic diseases for the 3 years of the study. And then over those 3 years, the outcomes we looked at included all-cause mortality, myocardial infarction, stroke, coronary revascularization, and then hospitalizations for those, and then other cardiovascular related conditions. We also looked at medication adherence, quality of life, and healthcare costs for these people as well. The participants who received that additional coverage saw a 3% increase in medication adherence for medications that lower blood pressure and cholesterol. But despite this increase in adherence that we saw, there was actually no significant difference in clinical outcomes between the control group and the full coverage group. There's also no difference in healthcare costs between the control group and the coverage group as well. So overall, we do have a paucity of randomized trials with clinical information. We have pretty limited RCTs actually giving coverage to people with no insurance, which does limit our application of these results to a subset of the population. Previous studies like the Zhang study looking at Medicare Part D, they do suggest that having insurance can increase the use of those indicated medications. But also these observational studies do raise concerns that low-income people and people without sufficient coverage can experience complications when facing cost sharing. The Clean Meds and the MI-Free studies showed that additional coverage can improve adherence, which could be actually argued to be the most important result, but it did show limited improvements in their actual clinical outcomes. And then in ACCESS, we did find that low-income seniors at high cardiovascular risk, when we reduced cost sharing from 30% co-insurance to 0% co-insurance, that did not have an effect on clinical outcomes, quality of life, or healthcare costs, despite that small increase in adherence of 3%. This did kind of lead us to the conclusion that perhaps having a small copay or co-insurance for prescriptions might be reasonable, but it's noteworthy that the study was conducted with participants who actually already had decent drug coverage, where they only had to pay a 30% co-insurance through the Seniors Blue Cross program, and those results might have been different in a population with no drug insurance. So with this really recent Canadian trial that we just published last year, giving up more information on cost sharing for public drug coverage, where costs are split between the government and individuals, we wanted to disseminate this knowledge to policymakers, and there was a pretty timely opportunity through a grant when we were working on putting the publication together. So we ended up receiving a CHR Health Policy grant, and we put a team together with policymakers across Canada, other researchers, and patient partners to try and make some recommendations for public drug policies in Canada, and then specifically Alberta. The thought was that if we worked on this summary and conducted a policy analysis, actually kind of working alongside these policymakers, we could take their priorities into account and hopefully end up with a usable product for them. And then to be able to do this policy analysis, we had to lay some groundwork. So the objectives for that were to identify and describe those different cost-sharing arrangements in public drug insurance for different groups of people across Canada, and then furthermore, to understand the strengths and weaknesses of those methods of cost sharing across Canada, specifically from the perspective of policymakers. So this led to working on an environmental scan and policymaker interviews. So to start off with the environmental scan, we first gathered information on existing public drug coverage plans from provincial and territorial websites, trying to focus specifically on plans that did use cost sharing of some form. Then we wrote summaries of those plans and shared them with the policymakers that we were in touch with to actually confirm that we got it right. And then, although those plans didn't really fit neatly into nice boxes of cost sharing method, we did try to group them together. And then we also looked at eligibility for those plans. So, some plans have plans, or some places have plans based on age or income or specific diseases as well. And then this is just a really quick look comparison of our results. So this is looking at the under 65 adult population for coverage. So specifically people not receiving social assistance, and then between premium-based systems where there's a regular fee that you pay out of pocket to have the coverage, and then deductible-based systems where there's a cost that you pay out of pocket before any insurance actually kicks in. So you can see that out of the provinces, only Quebec actually utilizes both the premium and the deductible-based systems. So it is noteworthy that deductible-based coverage, in particular income-based deductible coverage, where it's often on a sliding scale based on your income, is a more popular system across Canada compared to the premium-based systems that for non-senior adults, only Alberta, Quebec, and New Brunswick actually use. Premiums Alberta do have 2 tiers of income where you can receive a reduced premium if you're low income, and then Quebec and New Brunswick have more tiers dividing their system. So regardless of premium or deductible system, almost all provinces actually use copays or co-insurance, which is the cost that you pay when you actually pick up your prescriptions. And then some provinces have copays that scale on your income as well. So Manitoba is actually the only province that we found that doesn't use a copay in their system at all. They have a deductible-based system only for their pharmacare program. And I will point out that finding cost-sharing programs for adults in the territories was a bit difficult, as there isn't actually much in terms of public coverage systems that use cost-sharing outside of Yukon's deductible system. And there are also a number of chronic health conditions in the territories that actually result in full coverage. So we also ended up excluding the non-insured health benefits program for eligible First Nations and Inuit, as we kind of had to narrow our focus on provincial and territorial systems, and the NIHB is federally administered. Just a quick summary, even provinces that have the same approach to plans do differ in execution of those plans. And then multiple provinces use income-based deductible systems, but British Columbia is based kind of solely on income, whereas Manitoba's is based on income, household size, and drug costs. So even if they're using the same system, it still can differ. Many provinces offer additional coverage based on conditions like cystic fibrosis, diabetes, or like home cancer drugs, but conditions are not universally covered across the country as well. And many provinces also have additional coverage for people who have very low income or who are on social assistance, like Alberta's Assured Income for the Severely Handicapped program. So that provides like full coverage for adults who have that age benefit. And then another point to note is that when a research team has actually done simulations of medication burden across the country, it can vary pretty substantially. So high medication burden can range from $250 to $2,500 in out-of-pocket costs per year for the same conditions and the same medications. So your medication costs can be very dependent on where you're living in the country. So just moving on to the policymaker interviews. So assistant deputy ministers who are managing the pharmaceutical programs were contacted for an interview. And then we either had the interview with them or with a representative that they gave us, like an executive director. And these are the same people that we had review the summaries for the public plans that I discussed earlier in the environmental scan portion. We ended up having interviews with British Columbia, Alberta, Saskatchewan, Manitoba, Ontario, New Brunswick, PEI, and Nunavut. So unfortunately, we weren't able to interview everyone, but we did actually get a pretty good spread of plans from across the country. The interviews were semi-structured, so that means that we only had a number of questions to ask the policymakers. There was some flexibility built into the guide that kind of allowed for further probing into areas of interest, and the interviews lasted from 40 to 60 minutes. We asked like a number of questions kind of around their province and territories approach to drug policy design. So questions like, what do you think is working well with your plans and what could be kind of even better? And then also questions like, what is your province or territory's philosophy to covering people who are facing financial barriers? Some of the strengths that the policymakers talked about with regard to their plans included multiple policymakers discussing improvements that have made to their plans over the recent years, with policymakers feeling that, with the changes that they made, that there would be improvement for families, that they would be seeing improved coverage with, recent changes for their plans. Other provinces discussed how their plans were serving the population well, kind of thinking that the majority of the population would have some mechanism to pay for drug therapies, kind of referring to the universality of their coverage. And then some of the challenges they identified. Policymakers from provinces where government was the first payer of medications, so that means the government pays claims first and then leftover costs can be either covered out of pocket or by separate private insurance. They had a lot of difficulty tracking gaps in coverage as they had very little knowledge on kind of residents' private coverage. They're saying, it's very hard to understand where those gaps or what those gaps are because there's a very large percentage of people who are actually covered by private drug plans. Sustainability and cost issues were discussed very frequently. Multiple provinces talking about how they had, a changing population and changing drug needs, saying that there's ongoing sustainability challenges for the program that kind of grows faster than inflation can grow. And policymakers also talked about how drug costs continue to increase. So particularly kind of bringing up biologics and biosimilars, as well as drugs for rare diseases. So those all came up a lot when discussing cost with them. We did also ask policymakers about populations of people who were perhaps kind of the least well served with their current plans, and answers were actually pretty dependent on the type of cost sharing system that they utilized as well. A policymaker from a province that uses a income-based system discussed how they used actually income taxes to determine the level of cost sharing that people paid. And they brought up how people who aren't able to actually complete their income taxes were really difficult to get coverage set up for. An example they brought up were, people living on the street with HIV, kind of not doing their taxes for obvious reasons, and then submitting through the government to actually get coverage. So that's really a challenge for them, for that particular type of system. And then costs increasing by income tier also actually end up resulting in gaps in coverage sometimes, with the policymaker talking about how kind of jumping from like one income bracket to the next as their income increased resulted in actually significant underutilization of drugs by that cohort, as their drug costs could actually potentially increase beyond by what their income increased by. And then despite national plans not being a question that we asked, comments did come up about kind of a national pharmacare, understandably so. A policymaker noted that kind of creating a national formulary of drugs would be really difficult, saying, how do you cost share drugs for rare diseases? How do you agree like what's actually on there when discussing sharing the cost for some of those expensive drugs across the country? And just like provinces don't use the same formulary for all covered drugs, so it would have to be very different considering the provinces. And then certainly these policies also don't exist in a vacuum. So one policymaker noted that, whenever a province does something better than somebody else, we all get the pressure. So just to conclude, there is pretty substantial variation in public drug coverage plans across Canada, as kind of we saw from both the environmental scan and then from also the interviews. Coverage can depend and vary quite substantially based on age, income, health conditions, household size, dependents living in the home, place of residence, whether you're not receiving social assistance or disability, and other factors as well. And then commonly identified strengths included improvements made to systems and general thoughts the plans were working well and serving the residents well of the provinces and territories. And then commonly identified challenges included a changing population, especially an increasing senior population that was brought up quite frequently, increasing drug costs, and some administrative difficulties, which again varied kind of based on what kind of plan each province utilized. And then finally, provinces across Canada did routinely make improvements to plans, but tracking the impact that it actually had for the citizens was quite limited, as some provinces said, while some provinces do that tracking, other provinces said they just don't have the capacity to actually do efficacy tracking when they change their plans. Just some quick acknowledgements for people who worked on this project and our funders, and then I will actually hand it over to the next plan step, a policy analysis, and I'll hand over to Dr. Beall now.
Thank you, Jane. Let's bring my slides up. Okay, thank you so much, everyone, for being here. So as Jane said, I'm here to tell you about the policy analysis that followed the environmental scan. And just as a note, this is in progress, so welcome feedback along the way. Just to get started, I think Jane set this up really nicely. In terms of the background, there is a sizable proportion of the population that does not have health insurance to pay for prescription drugs. And we decided to focus on the issue of how to expand coverage to those groups within Alberta specifically. So we formed kind of a smaller working group to focus on Alberta's situation specifically. Our method was to use a traditional public policy analysis framework that might be unfamiliar to the audience, and my role in the project has really been to bring that experience with public policy analysis to this question. So the steps of a public policy analysis, as we have used it and applied it, has been to establish a team of analysts and then separately a stakeholder panel, which can include patient partners, but also experts to speak to the issues, as well as decision makers. Then you define the problem that you're trying to solve and agree upon that as a group. Then you decide, once you go out looking for policy options, how are you going to decide between those and prioritize them and establish the decision criteria. Then you go out and actually find the different policy options. And so the environment scan really served well for that step. And then once you've narrowed the options that you want to evaluate and are contenders for the top option, then you go ahead and do a deep dive and score them. And I'll talk through each of these steps along the way. And then once you've identified your top option, then you go about designing implementation and monitoring recommendations and ultimately make your recommendation. So I'll just walk through each stage of this process and give you a bit of an update on where we're at and how we applied it in this particular case. So we had 3 analysts. One is a student, another is a legal analyst on our team, and another is a policy analyst. And these are the ones who are going to really drive the analysis forward. Then we also established a stakeholder panel. We ended up having 2. One consisted of patient partners with lived experience, and then the others had policy actors and experts on it. And that included members from Alberta Health as well as Alberta Blue Cross. And we also had Braden Manns function as an expert, as well as Carrie McBrien, who some in the audience may know. Then moving on to the policy problem, we drafted a number of different possibilities, and eventually as a group agreed on the following one here. Too many working people in Alberta face unaffordable access or financial barriers to prescription drug insurance coverage. In terms of problem statements, just a couple of best practices, in case the wording sounds a bit awkward to some, is we found it extremely useful, and it is recommended in the literature to think about deficit and excess. What things are you trying to improve or eliminate as a policy goal? Others are stripping causal claims or consequences, or somehow framing your pet solution into the problem statement, are other kinds of pitfalls. So after quite a bit of work, we arrived at this one, and it may be subject to further revision, but this is where we're at right now. So looking at the policy problem and trying to understand the status quo of what's going on right now, currently we're still analyzing some data from the Canadian Community Health Survey, which was released just on Friday last week. But it does show what we kind of suspected, which was that in the income range between 20 and 40,000, and in particular, the age group from 19 to 34 seems to be where most people are reporting not having any kind of prescription drug insurance. So as we are formulating policy options, we thought about that group in particular. Here are the odds for those particular groups in a larger model. The reason I wanted to show this is that if you look at that previous slide, it does actually look like the 55 to 64 group has the largest number of those reporting that, but that was not controlled for many of the other factors that are in our model. So yeah, it's that 19 to 34 age group that's making between 20 and 40,000 that seems to have the highest level of this. Next was to establish our decision criteria. So this is how we are going to decide which policy option to go with once we go out and find them. There are a number of them that are in the literature. One that I particularly like and have used quite often is from the National Collaborating Center for Healthy Public Policy. And the reason I like it is it seems to encapsulate a lot of the other ones out there. So it really seems to have done a good job of capturing what most people in public policy see as the key considerations. So they have 6 in total. They're broken down into 2 sets, one focusing on impact and the other upon implementation. So effectiveness is really, will this actually do what we hope it will do? And then the next is unintended consequences. So there's some externalities that need to be taken into consideration, both positive ones and negative ones. And then equity. So are there differential impacts on the target population? So subgroups within the target population that we need to think about being particularly impacted. In terms of implementation, these are really questions around, if we do this, could we actually, if we decide to do this, could we actually put it into action? So cost is obviously going to be a consideration. Is this going to be cost neutral, or is it going to cost quite a bit, or will it even save money to make the particular decision? Feasibility, that is really, are there kind of technical things that would prevent us from doing this? Do new systems need to be built? Are there laws that would block the particular option, and so forth? And then acceptability refers to support from either the end users or decision makers or other stakeholders who can influence the problem. And is that policy option acceptable to them, or are there groups that are not in favor of it? So after agreeing upon the particular decision criteria, the next step is to go through and create a rubric of, okay, once we go and look at the literature and look at the policy options, how is it that we're going to score them? And ideally, as the 3 analysts do this, they'd be able to look at the literature and come to more or less the same score. So you can use more scores than just 3, but I like to begin with 3 and go to 4 or 5 if needed. And my favorite way to do this is to come up with the dream scenario, the strongest option that we think would be the ideal solution. Whether or not it actually exists is not a question when doing this exercise. Then to create the weak option, you basically reverse the dream scenario, and that would give you your nightmare scenario. And then you've got everything in the middle. So this is just an example of 3 from the impact category of how we went about defining these. Okay, so then we went out and started looking for policy options. So in public policy analysis, the #1 policy option is always going to be the status quo. So it's just keeping business as usual. It's the do nothing approach. And so Jane already gave a synopsis of what the coverage is for those in our target population in Alberta. So there are two income tiers, basically, and we have both a premium and then a co-insurance to go along with that, up to $25. The status quo, it's important to think about the merits of the particular plan, how it came to be, and really give it credit for the successes that it's had, as well as acknowledging where some strengthening could happen. So after identifying about, we had 7 different policy options. After doing an initial scoring and consulting our stakeholder groups, we arrived at these 3 for the deep dive full analysis, and that's where we're at right now. So option 1 being the status quo, keeping things the exact same way as they are. Option number 2 would be expanding the tiered pricing structure for premiums. So rather than just having 2, we'd increase those up to 4 or 5, but keep the co-insurance the same and keep the cap the same. So the only change would be introducing more income brackets. Then option 3 would be both more income brackets plus moving to a co-payment model per prescription. In both cases, you could also introduce income tiers to the co-insurance or the co-payment structure as well. So as we've gone into the deep dive, just to give you a bit of better sense of what it looks like as you approach the literature. So we did a relevance screening, brought in the literature that passed through those phases. There are also conveniently 2 recently done systematic reviews, which we relied upon as well. And then you go through the literature and you start coding what is relevant to each decision criteria, and then write up summaries for those. So here's an example with unintended effects, feasibility, and acceptability. This slide, by the way, comes from the National Collaborating Center on Healthy Public Policy. Okay, so these are our preliminary results. So status quo and option 3 scored lower than option 2. So that's the tiered pricing restructure with co-insurance. So the only thing we're changing is introducing more income tiers. And you can see here that analysts had some places where they disagreed and other places where they all agreed. And although option 2 looks like it is leading the pack, but we'll see where we land after completing the deep dive into the literature. And we have a few more expert consultations scheduled as well. So in terms of where we're going next, we're going to continue revising as we go through the literature. As I said, a few more expert consultations. Once we've identified our final recommendation, then we go about making implementation and monitoring recommendations. And what's involved there is making some recommendations to not only address the weaknesses of that option, but also to focus on the positive aspects of it to maximize it. And then in terms of monitoring, it's how do we monitor the intermediate steps of the ultimate effect that we want to see, and what strategies are we going to use for that. So it's thinking about surveys, interviews, what kind of quantitative data we have to monitor to make sure that what we want to happen is actually happening. Then of course, writing up the policy brief and briefing notes, and deliver that to our stakeholders, as well as submit the final manuscript. So in terms of some evidence that we're hunting for right now, of course, if there's the exact situation that we're talking about, particularly for policy option 2, we'd love to hear about it. We've found some studies of similar situations, but not the exact situation of moving from fewer tiers to more tiers in the premium bracket to hopefully entice more to enroll in the plan. So please let us know if you are familiar with some of that evidence. I'm often asked for just some resources on public policy analysis. We wrote up a article describing the whole process that I just gave you with a different topic. It's highlighted here below. Otherwise, I found these resources to be extremely useful, and I can share these slides with the links to those as well. And that's it for where we are at with the policy analysis. Thanks so much.
Hey, thank you both Jane and Reid for this a great presentation. Very interesting information that you shared. Before we get into the question and answer period, I feel like I should probably do a very quick introduction for myself. So my name is Brian. I'm one of the new principal senior health economists here at IHE, and I believe I'll be taking over the management of the rounds in the fall. So just want to say hello to everyone. And now I thank you both for this amazing presentation, and would like to invite the attendees to type out some questions that you have in the Q&A button and the Zoom software menu. And we already have some questions and comments already in the Q&A in the Zoom. And so I'll read them out to you, and I guess we can address them one at a time. So sorry if I pronounced your name incorrectly, but I think it's Alai. Their question is, how did you define low-income Albertans in the trial? I believe this is a question for Jane. Is there any specific database for that?
Yeah, so I think they're referring to specifically the access trial. So it was just like self-report income for having like less than $50,000 household income per year. But kind of the interesting thing is that like there's some discussion on whether income is actually the best way to actually measure financial barriers or not. So in the access trial, although it wasn't a like criterion for inclusion, we also asked kind of assess their level of financial barriers that they reported. So kind of asking, you know, like how often are you having difficulties affording the supplies you need for your chronic diseases, or like how often do you just not get those due to cost, and kind of determining if they had absent, moderate or severe financial barriers based on that. But yeah, the straight answer is that we just asked them, and less than $50,000 a year household income.
Excellent. Okay, thank you. I hope that answers your question. So I'm going to move on to the next question. Let me know if you want any clarification there. So there's a comment and a question by Deborah Marshall, and she starts off by thanking you, Jane. It's said that it's a really nice piece of work to document the details of the variation. And the question that she has is, has your work factored into any of the discussion around the NDP?
So Deborah, I assume it's kind of like you're talking about the NDP, Liberal like Pharmacare Alliance.
I assume that is what she's referring to, but you can clarify if that's not the case.
So we have had some discussions because we reached out to like the federal minister in charge of developing like the Pharmacare plan to ask if they're interested in this work, and they were. We haven't been able to have like kind of multiple discussions with how the policy analysis impacts it. I don't know if Reid wants to expand on that, but so far we've shared the work with them and kind of waiting to see if they would like more from us.
And Reid, did you have anything to add? No, I saw your head nod, but okay, excellent. Okay, you're on mute. Okay, so the next question that we have here. I believe it's either a question or a comment, but I'll read it out anyways. And I don't have a name for it, but it's an anonymous attendee. And it's a question for Dr. Beall. It's wondering, did you consider increasing the co-insurance maximum to help offset the incremental expenditures that would be caused by reducing the premiums for lower income Albertans? So they mentioned here, based on the access study, it looks like there isn't a significant barrier caused by co-insurance. It's also my understanding that Alberta has not adjusted its co-insurance levels in decades. So it's 30% up to a maximum of $25.
Yes. So I think that's kind of a two-part question, but it raises a really interesting issue of if we make these changes, with that may come more cost. Regarding the co-insurance levels, so we're not thinking about, we're not suggesting necessarily making any changes there. Our main interest for this analysis is expanding the number of people enrolled. So by changing premiums to be lower, the hope is that more in the lower income brackets would actually enroll in the plan. And as pointed out in the comment, unintended consequence of that may be that those in higher tiers who suddenly experience higher premiums would unenroll. And there might be a disparity there in terms of cost. One super interesting empirical finding that we found in our literature review is that those in the higher income brackets are less price sensitive or responsive than those in the lower income brackets. So we'd expect more in the lower income brackets to be enticed to join, and fewer in the higher income brackets to be bothered by having a slight increase to their monthly premium. In theory, this could work. I'm not saying that it would offset each other entirely, but certainly there would be some contribution gained in that. In terms of other costs, hopefully there would be cost deferral for better adherence for those who suddenly have drug coverage. Also, the key group that we're really looking at tends to be younger, and therefore they tend to have fewer health problems. So as they're paying into the system, they might be those who are actually cheaper to cover as well. So there's a modeling exercise that we'll put some recommendations around to find hopefully the optimal income brackets to create. So I think that kind of covers my response to that comment.
Mm-hmm. Sort of like a differential impact because of the different price sensitivities for the income brackets, right?
Right.
Okay, excellent. Okay, I hope that answers your question. Next is a comment from Scott Robertson, and they want to say, thanks for allowing me to join from the Northwest Territories. It's often lonely up here as a health economist. So I think that was she was probably part of the collaboration on the project. So thank you for that comment. Next one is a question from Mark. And he starts off by saying, thank you, great presentation, thank you. I have a follow-up question from Jane's part of the presentation. One conclusion from the interviews was that provinces routinely make improvements, but have little ability to monitor the outcomes. Could you describe a little more about what decision makers thought was making these changes positive, and who were the changes positive for?
Yeah, so kind of like I was saying, a common question that I was asking during the interviews was, if when they're talking about all these changes that they're making, if they are making changes, is there actually any kind of before after monitoring of whether or not, improving coverage for this group or maybe like taking away some coverage for another group did actually result in any meaningful change in hospitalizations or like adherence, medication utilization. And the general consensus, not universal, but for most provinces, is that a lot of these kind of individual improvements where they're saying, we're going to increase coverage for this group, or we're going to, like bump up the coverage a little bit for this group, were almost made on like a kind of ad hoc basis where they were hearing kind of a lot of pressure, or feeling a lot of pressure from either like government or like certain like working groups to improve coverage for a certain group, and they would improve coverage if possible and then kind of like move on without actually doing any kind of evaluation on it. So I think it was more the fact that they thought the positive changes were coming from that they just provided improved coverage, or they kind of expanded coverage for certain groups, not from any actual like hard data, I would say. But there are provinces that actually do more kind of efficacy studies. Like there's a lot of interesting stuff coming out of BC that's looking at, making changes to coverage programs and seeing if that actually makes a difference. But overall, I think it was more so that the thought of providing additional coverage for a group does mean that it's like better for them.
Mm-hmm. So just the success of moving that policy forward was itself a marker of success, right?
Yes, without kind of saying like we tracked a 4% increase in, adherence and reduced hospitalizations for this group. I think more so that it was just the policy was changed.
Yeah, right. Okay, thank you for that question, and I hope that answered Mark's question there. Another question and comment from Scott. More comment on medication access. He says, I did an analysis of data from an insurer in the US, and it was remarkable how even small changes in costs, so for example, 25 cents per day per dose, had a significant impact on medication possession ratio. Is there any data anywhere in Canada that matches prescriber with fill data on a large scale?
So I guess by prescriber, I'm not sure exactly, like, would that be kind of prescriber for private insurance, or I guess prescribe, I don't know if I can make a guess on that. But I know with like access, how we tracked adherence was looking at fill data from pharmacists. And I don't know of any very large studies on like a Canada scale that is kind of looking at prescriber and fill data based on what kind of insurance they have. I don't know if, Reed, if you have any thoughts on this.
No, I was just trying to think of that. It seems like it's a pretty common problem that we don't know which health insurance plan they have. A lot of times we can see that whether or not they have the public plan, but in the private realm, it makes it really difficult to do that analysis. I've done quite a bit of work to see what kind of data we can get on the uninsured population here in Alberta and in other provinces. It's particularly difficult. But it does seem like the Canadian Community Health Survey is the best option. So we're just basically asking people, which is not utilization data. So unfortunately, I don't have a good response to that question.
Yeah, that's definitely one of the limitations with the Community Health Survey, right? It's asking them for their perception on their health. And yeah, you're correct. Private insurers are not the most open in sharing their data as well. It's quite a struggle. Okay, so I hope that answers your question, Scott. Moving on, Deborah has a few comments, and actually, I think mostly comments here. Thanks to Reed too. Really nice to have this careful analysis about options. And here's the question. How do you see this translating into the current policy discussions? And I'll read up the following questions because I think they're related to that one. And it says, how do you weight the options in the policy scenario analysis? And then just a thank you to Jane, realizing that after typing NDP, it could mean more than one thing, but I think you got it right there. So yeah, the two questions from Deborah about how you see translation into policy and how do you weight.
Um, I guess I'll start with the weighting question. So in terms of how to weight the analysis, I think the question is, how do you arrive at the scores? So for that, we use the decision rubric to look at the evidence and then assign a score based on the characteristics that we see and what we agreed upon prior to going to the literature. It is possible to actually assign a heavier weight to some criteria versus others. So you could decide effectiveness and cost are most important in this scenario, and therefore will double the weight of those. And then you can run a sensitivity analysis to see, well, if you remove that weighting, does it actually change the answer that you get? In this particular approach, we've been weighting all of the 6 criteria equally. So that's how we came up with a score, just a 1, 2, or 3. And then in terms of the NDP situation, we are factoring that in as well under the acceptability decision criteria.
Excellent. Just a follow-up question to that. In terms of the weighting, were there several, you may have mentioned this, but were there several people who put weight in their decision on the weight, and how did you derive a score if there's more than one individual?
So we'll take an average.
Okay.
However, we do, after everyone in all the 3 analysts independently scored, then we have a conversation about particularly where there's margin of disagreement and come to some consensus. But a lot of times you can't arrive at an agreement. And so in that case, we just take an average. In the ideal scenario, though, if your rubric is really tight and you've kind of run a few tests prior to going to the literature, you can, a lot of people arrive at the same score.
Okay, interesting. So I encourage people who may have some last minute questions to please feel free to put in the question and answer option for Zoom. And I do have one question. If I understood the analysis or the methods correctly for your study read. So with the 3 options, it looks like the 3 options was status quo, and then more tiers, and then more tiers with a change in, I believe it's to co-payment. How do you avoid, and I don't know if this is a legitimate concern or not, but how do you avoid I guess, the Goldilocks effect? That being that the middle option is the best option because it's not as extreme as the 3rd option, but it's better than status quo.
That's a great question. As you go through the criteria, because they're separated nicely into those 6 different dimensions, each will really shine in different ways. And in the end, usually that helps you kind of avoid always recommending the middle option. However, a lot of times when you're making your implementation recommendations, it could be, let's start here, and in a stage process, move on to adding the additional component that we think will really maximize impact. And in that scenario, you are kind of recommending both in the end. So that's another way of dealing with that potential issue. But a lot of decision makers, in the here and now, they can only choose one. So for the analysis, that's what we do is one at a time.
Okay, excellent. And I had one more question in the Q&A, whether it's possible to share the slides.
Yes, absolutely.
Okay, good. So I guess we'll figure out how to get that done. But Yeah, those were great slides as well. Okay, so thank you both, Jane and Reid, for this great presentation and the answering those questions afterwards. That was a great discussion. I'd like to thank everyone online for attending, and a note. Oh, there we go. Nicole posted that the slides will be posted on NOAHE.ca. So a few notes to end off the rounds today. So if there are any further questions after today's webinar, we do encourage them to be sent via email to noahe@ihe.ca. So noahe@ihe.ca. So today marks the final seminar of NOAA rounds. And the information about next year's series will be posted to noahe.ca as details are confirmed. So this is a reminder that the call for abstract submissions for October's Health Econ Study Group is open, and the deadline for that is July 15th. Please reach out to Nicole if you have any questions about that. Also, please visit noahe.ca to subscribe to our mailing list to stay up to date on all NOAA activities. So once again, thank you both Jane and Reid for this great presentation today. And I thank everyone for attending this year's rounds.